Hey guys, this is going to be chapter 2 that you guys are going to actually listen to outside of class. We're not going to be covering this in lecture at all. So it's really important for you guys to watch this video and to read the chapter because we won't have very much time and we won't really talk about it in person. Chapter 2 is on the U.S. healthcare delivery system. And this is a really complex and constantly changing system because it constantly evolves. And as the healthcare delivery system evolves, so does nursing practice. And that's definitely related to the level of technology that we have available. But it's also related to evidence-based practice, which is when evidence shows that it's safer to do something a certain way, we change our practice towards that evidence. And then healthcare policy at the federal and state level is a really important example because our practice definitely changes when policy changes. And so it's important for you guys to understand this chapter because as a nurse, you'll face a lot of challenges in the healthcare delivery system and just in healthcare in general. And so understanding what your patients are going through and what system they're in will help you provide better care. And we'll have a lot of challenges just for the population. And so as a nurse, it's important for you to find those gaps that your patients are falling into so that we can help prevent them and change them later. Because we're the last safety net and we're the caretakers that are there at the bedside with the patients. So let's continue. So challenges to healthcare. Obviously, the first one that comes to mind is going to be uninsured patients. We kind of talked about this on Thursday, but uninsured patients present a challenge because they're more likely to skip or delay treatment for any of their illnesses, and they actually die a lot more prematurely because they can't seek health care because they can't afford it. They will have these huge high fevers, like 106 degrees. They'll be having seizures. They'll have these wounds that won't heal, and they won't seek care because they can't afford to go to a primary care doctor. And so this is a challenge because when we're nurses, we can't reach them until they come to us. And so we don't see those gaps until they finally give up and decide to try to pay for the health care that they're going to receive. And so it's really a challenging area for your patients to be in because you know that they most likely can't afford the care that they're receiving. And so that's going to always kind of be at the top. And so a lot of the policy and things that are changing over these last few decades is to try to close those gaps in our uninsured patient population so that we can reach everybody and actually care for everybody and the right that they have to health care. So the next challenge is going to be that earlier hospital discharges are resulting in the patients going to home care or nursing homes. And this is a thing kind of directly related to the insurance policy because insurance says that once they meet a certain criteria, they're not eligible to stay in the hospital or stay in the acute care facilities anymore. And so we're having to discharge them to home care or nursing homes. And the challenge with home care is that when they're not under direct supervision immediately, they might not be taking their medications correctly, or they might miss visits or decline visits when we come to see them. So it's kind of a difficult space for the patients to be in because if we're discharging them before they've received the proper education, like what we talked about on Thursday, if they don't know what they need to come back in for, or if they don't know how to take their medications correctly, then we're actually going to be creating more problems than helping them. So early hospital discharges are kind of a big deal just because they kind of directly relate to how we, as nurses, do their discharge planning. So then the next challenge is going to be that the healthcare system we have now is a lot less service-oriented than it used to be because it has to be business-oriented. And this is because of cost-saving initiatives. So, for example, most of the hospitals in Oklahoma City are within their own healthcare system. So Baptist Hospital is under the Integris system. And this is just an example from turning from service to cost effective because patient satisfaction and the cost of healthcare is so important for these businesses because they're now for-profit organizations, and they are businesses in and of themselves. So our delivery of healthcare kind of changes from this, holistic caring model to a, very business oriented. You're going to get charged this much for the medication that I'm going to provide you, things like that. So that's definitely a challenge to healthcare because it changes how we care for our patients. So then, as we change into more of a business system, there's, healthcare reform that's happened in the past that backs that up. So back in 1983, the government created this prospective payment system, and this was established to eliminate cost-based reimbursement. So before that time, with cost-based reimbursement, physicians were able to charge patients based on what procedures or things they did for them. But now, Medicare patients specifically, or anybody under government-regulated insurance or insurance in general, is creating these diagnosis-related groups. And these DRGs, for short, provide fixed reimbursement with little tiny adjustments based on diagnosis and potential cost. So everything spent above that amount is not covered. So if you come in for pneumonia, they're guessing that, this is totally a guess, not real, that maybe your cost for that treatment should be about like $7,000. So if that cost for that care is higher than that, that's not covered at all. And so it either goes back to the physician who's ordering unnecessary tests, or it's paid out by the patient. So capitation is these providers receiving a fixed amount per patient or enrollee in these healthcare plans. And so physicians try to kind of combat this because they might have to see a certain amount of patients to actually get the monies that are due them from the insurance companies. So it definitely messes with the ability for us to care for them, but it also has lower costs because the healthcare providers are not ordering unnecessary exams, they're not ordering unnecessary lab work, things like that. So it kind of has lowered cost over the long run, and has actually saved a lot of money because it looks more at, hey, we see these like groups of diagnoses, and this is approximately how much it should cost based on the tests that they need to do for this. And so everything above that we might not cover unless you can prove it, and then that would be an adjustment that it needed to be covered. So then the next one that helps cover cost is called managed care. And this is where healthcare systems have providers that receive a predetermined capitated payment for each patient. And so these are already looking at lowering costs to keep things fair for the patients. Excuse me. So this is only charging the patient for labs and testing only if the patient requires it. And it saves the patient in the US a lot of money. So interestingly, back in 2011, the National Quality Forum made this list of 29 never events. And these are devastating events because, first of all, they're preventable. And so these have caused death or dismemberment or traumatic scars or traumatic issues or anything like that. And they have these 7 different categories, like surgical, product or device, patient protection, care management, environment, critical, things like that. And so if something happens in your hospital or a clinic that is one of these events, you're not paid by insurance at all because they're considered preventable events. And so we'll talk about this a lot more in lab as we get towards, especially on Thursday when we learn about Foley catheters. If we get an infection from a Foley catheter, or if our patient gets an infection from a Foley, that's not reimbursed at all through Medicare or Medicaid. Sorry, my throat. And so we have to look at that and look at those procedures and policies because these are all preventive things that are happening, and our patients can get really sick from a UTI that's caused by our practice. So we'll look closer at that when we're in lab at those specific things that might not be reimbursed. So right now we're under the Patient Protection and Affordable Care Act, or Obamacare. This was passed in 2010, and it focuses on these huge major goals that are trying to increase access to healthcare services for everyone, reduce healthcare costs, and improve quality. And these kind of have created these provisions so that we can reform insurance and reform the care in the healthcare system so that we can actually provide care for everybody with low costs with high quality. So the first one is insurance industry reforms, and this actually helped create insurance where they can't deny pre-existing coverage or pre-existing conditions. So if you had asthma before, when you would search for different insurance companies, you might not be covered for the asthma medication because they know it's a chronic illness. But this Patient Protection and Affordable Care Act got rid of that, and so now if you have asthma, you can be covered under the Affordable Care Act. Increasing funding for public programs. This is like education, no smoking signs, anything public. So free clinics, public awareness, a lot of the ads and things that we see for health regulation, things like that are all increased funding so that we can help prevent do preventive care effectively. And then the provisions for the children, the improved coverage, this is going to be where they allow insurance companies to keep adult children on their parents' plans until they're 26 years old. So this kind of helps bridge that gap because they were seeing that there's this huge gap where these kids are leaving their parents' house at 18 years old or whatever, going and getting a job, not getting health insurance, and then they're getting really ill or they're hurting themselves, but they're not seeking appropriate care or going to a primary care provider because they don't have insurance coverage. So this closes that gap at least so that children can stay on their parents' plan during that time. So the emphasis now is on population wellness instead of managing illness. And so a lot of our healthcare services have changed to preventive medicine. And this kind of starts at the population level, and then it goes into acute care and then into like rehab facilities. So the emphasis now is a lot more on what we can do to prevent illness and keep people from coming in being really, really ill. So the Core Functions Project developed this health services pyramid, and this shows that the population healthcare services provide the basis for the preventive services, and then these clinical preventive services provide the base for like primary healthcare, secondary, and tertiary, which we learned about on Thursday. So the life expectancy for Americans has shown a steady increase because we've had a reduction in mortality rates because of the increase in sanitation and technology and the increased work in preventive medicine for infectious diseases like increasing hand hygiene and things like that. And then patient teaching has gone up a lot because we've emphasized wellness and patient teaching closer to discharge so that our patients understand what they need to do when they go home. And then injury prevention programs. These are going to be really important because they'll prevent patients from coming in with really expensive broken bones or, falls, things like that. I'll send you all this link in a separate link. It's just an interesting video that kind of encapsulates what we're talking about here, about our patients' access to coverage and about why they're coming in so sick. And it kind of talks about a little bit of what we talked about on Thursday. So it's only 2 minutes long if you want to check it out. It's kind of interesting. So now we need to look at Medicare and Medicaid. So these are federal and state programs that really increase the ability and accessibility for people to get insurance. And so Medicare is federally covered mainly. And this is for clients that are only older than 65 years of age or if they have permanent disabilities. So underneath Medicare, there's these 4 different parts. And Part A is the hospital insurance. This is what people opt into. It doesn't cost extra. Everybody's covered under Medicare for hospital insurance. Part B has a little bit of an additional cost, but this provides medical insurance, and this allows these people to go to primary care providers, and they might pay like a little bit more each month, but they don't have to pay co-pays or things like that when they go see a primary care provider because they're opting into more preventive medicine. Part C is going to be the Advantage plan, and this is a little bit of an additional cost, but this allows you to see your own providers. So it just opens up the network for you to see the doctors that you want to see. Part D is a little bit more expensive, but you can opt into any or none of B, C, and D. And Part D just covers medications and prescriptions so that you're not paying $400 for the medicines that you need each month. Maybe you're paying $15, things like that. And so then Medicaid is mainly a state funded, and that's the big difference. Medicare is federally, Medicaid is mainly state, but it is a little bit federally, but very little in comparison to Medicare. And these determine eligibility because of permanent disability, or low income. So Medicaid is for those people that are at or below the poverty level, so that they can receive the insurance care that they definitely can't afford. And Medicaid is cool because parents can apply for their children to have insurance. So the parents might not qualify for Medicaid in and of themselves, but they can go ahead and get their children Medicaid. And these two programs really just benefit the country, but they obviously still have really big holes because if you're right above the threshold for Medicaid, for like your income level, then you're not going to qualify for insurance under Medicaid, but you're probably also not going to be able to afford your own insurance. So there's still a lot of gaps that we need to look at over these next few years that hopefully we can cover and get all these people covered with insurance that they can actually afford and make healthcare more accessible. So the issues in healthcare delivery. So you guys are going to hear so much about the nursing shortage because my gosh, we're getting degrees in a area that's always going to need people. So even though we have so many nurses, like I think it's 4 nurses to every person in the Army, like it's something insane. There's still a critical shortage, and it's projected to go all the way into 2022. But then it'll keep growing as this baby boomer generation retires, because our patient population is going to continue to increase. They're the biggest generation thus far. And as they seek higher care and very acute care as they age, the need for nurses is going to increase. So there's a lot of work to be done to help cover the nursing shortage and to help schools create nurses and build nurses and educate nurses that are going to be effective in care. Let's see. The nursing shortage is a big deal for all of us because working in understaffed units is kind of a big deal for this next section, like the quality and safety, because patient safety is a big deal. And if you are working in an understaffed unit, you might not be able to catch things as quickly or spend the time that you need to because you have too many patients. So the nursing shortage is you're gonna see it go into all things, and you guys talk about a lot of this in trends and issues when you get to that in senior year. But safety is always going to be a critical part of quality healthcare. So the first thing is the definition of quality healthcare is a healthcare system that can report desired outcomes, health outcomes, that are consistent with current professional knowledge. So these have developed these programs. So pay for performance are in public reporting. So these go through and they look at the hospital quality data that they're reporting quarterly, and these are designed to promote quality, effective, and safe patient care by the physicians and the healthcare organizations. There are quality improvement strategies, and they really just reward excellence. They pay back higher dividends, higher reimbursement if the hospitals and the care providers are providing excellent care. So this kind of just automatically gives them some sort of incentive to actually be financially fiscal, but also to provide really good care. And then the patient satisfaction. So every major healthcare organization, they measure certain aspects of patient satisfaction. And the main one you're going to hear about are these HCAHPS scores. And that's the Hospital Consumer Assessment of Healthcare Providers and Systems. And this is a standardized survey that's been developed to measure patient perceptions of their hospital experience. So when people go to the hospital and they're admitted, they'll leave and receive a phone call or receive a survey in the mail, and it'll ask you really specific questions, like, was your pain always managed? Were your call lights always answered in a timely manner? What are some other ones? Things like that. And the hospitals actually report on these quarterly, so there's a website there you guys can go and look at the hospitals that maybe you're looking at working at, or maybe you've already worked at as a nurse tech or something, and compare and see this data that's always been reported. And it looks at different diagnoses and hospital readmission rates and things like that. The important thing with patient satisfaction is that we try to provide patient-centered care, but it's going to always be important that when you meet that patient, that you're setting realistic expectations for whatever unit or whatever area you work in. So for instance, I work in ICU, so setting realistic expectations that, like, right off the bat, they're not going to be able to eat anything for a while until we figure out what's going on with them, unless the doctor orders a diet. There's going to be a lot of alarms, things like that, so that they know what to expect, so that they're not caught off guard and they're not annoyed by the noises. Things like that are going to be important for patient satisfaction. Quality, performance, and improvement. So every healthcare organization gathers data on a number of healthcare outcome measures so that it can gauge and improve its quality of care. So quality data are the outcome of these quality improvement and performance improvement initiatives. Quality improvement is this approach to a continuous study over the processes of providing healthcare services so that we can meet the needs of patients and others, and we can actually change policy. So this is the way we actually get to provide healthcare. We have to look, so when we provide healthcare, we have to look at what's happening all the way up into that point. How can we streamline a patient that's coming from the ER all the way into the inpatient admission of the hospital? How can we make that quicker? How can we make that better quality? Things like that are what quality improvement looks like. Performance measurement is going to analyze what an institution does and how well it does it. So in performance improvement, the organization itself analyzes and evaluates their own performance and use the results to develop focused improvement actions. So this is going to be if a unit decided to look at pain control and they found out that their patient's pain is not controlled very well, they're going to go into these performance improvements so that they can figure out what's going on and why their performance is so low, so that they can analyze that data and fix it very quickly. So it allows you to look at within an organization what's going on, and these inform evidence-based practice changes. So let's see. A well-organized quality improvement program is going to look at processes or systems that contribute to patient, staff, or system outcomes. It begins at the staff level, so the nurse level, so that you guys are going to be going on these quality improvement groups. They're going to pull you aside and be like, hey, how can we make this a better thing? What can we do to make this streamlined and quicker? It'll look at providing quality care to the patients and look at the best opportunity to improve that quality, and look for things that are high risk, or maybe they have 12 nurses working in an area that would only require 8. So how do we make this streamlined? Things like that are going to be what they're going to look at. So some models for the quality improvement is going to be the Plan, Do, Study, Act cycle. And this is going to be, so the plan area is they're going to look at the normal data and see what they're already doing and see some problems that already need change. So they're going to, the next one is Do. So they're going to select an intervention on the data that's been reviewed and implement that change really low level, so that they can see if there's actually a good outcome. And at the study level, we're going to evaluate the results of our do section. And if it actually works, did it actually make things better, we will act on it and we'll create different policy and regulations in the hospital. So this is kind of an important one because you'll see this kind of everywhere. They'll look at like streamlining how patients come from the ER to the floor. How can we make that a quicker area? How can we reduce CODIs? We did a Plan, Do, Study, Act on PICC line infections, and now we have our PICC team nurses come and do our dressing changes for us, things like that, to prevent infection. The lean one is going to be, how can we make this more fiscally responsible? So how can we make something cost less? Are we looking at things that take 12 minutes long when we don't need it to be? So Mercy did this thing. We were automatically swabbing everybody for MRSA in their NAIRS, and you'll learn a lot about this in nursing school. But when that happens, if it comes back positive, even though most people have it, you have to gown up and go on contact precautions. And we were literally wasting hours of each day just putting these gowns on. And so they made it a different thing. So now we give everybody CHG baths, which is chlorhexidine gluconate, and that'll prevent MRSA from ever even occurring and getting in their wounds. So now we only test high-risk patients for it. And that has allowed us to be fiscally conservative with the gowns that we were buying. And we're kind of protecting every patient from contracting MRSA. So it's kind of a big deal, and one way that Mercy did that. And then the next really important one is these rapid cycle improvement or rapid improvement events. So these are going to be things that are really intense, really short term. They usually happen in 1 week. And they make really radical changes to current processes really, really quick. They are used when a serious problem exists that can really affect patient safety. So anything that can be potentially deadly. Lack of recalling of critical results, medication errors, the nurses aren't acting quickly enough on chest pain because they don't have a policy or anything that they can have standing orders for. Things like that are what rapid cycle improvement would be involved in, so that we can make protocols and policies and kind of fix the error before it happens. So once these quality improvement committees make these changes, they'll communicate the results to the staff and be like, hey, this is what we're doing and this is why we're doing it. And then you'll kind of keep revising these improvements as you go, as you see they're more fiscally responsible and things like that. So our last slide. So the future of healthcare is going to look at opportunities for improvement. You guys are going to be on the front lines of change and the front lines of making improvements in quality and providing effective care for your patients. And you're going to be able to look at the gaps in the uninsured and see why patients aren't seeking help and things like that, and serve these underserved populations and kind of make change for the next generation of nurses. And this is important because you guys are already receiving high quality education by getting your bachelor's. And you guys are eligible and like totally qualified to go rally at state and federal level to look for change in the healthcare system. But it's going to be always important that you guys remain knowledgeable and proactive about issues in the healthcare delivery system so that we can keep providing quality patient care and positively affect healthcare. And we'll kind of get into who to delegate to and who else is in the healthcare system that will help enact change with us. And your ATI book is super helpful in this chapter especially. I can't remember which chapter it is in your ATI book, but it covers all this information on a very summarized level so that you guys can look at it all at once. So if you guys have any questions about this content, just email me and I'll get back to you as soon as I can. I hope you guys are all having a really good week. And I'll see you all on Tuesday. Bye.